Hey there, I'm Dr. Eric Arzubi, board certified child and adolescent psychiatrist and CEO of Frontier Psychiatry. And today we're going to talk about trauma-informed care and finding ways that you can recognize youth who have been exposed to adverse childhood experiences and then what to do to help those youth. One of the things I think is important to recognize is that exposure to adverse childhood experiences or toxic stress in early childhood is way more common than we'd like to think. And so keeping that in mind, chances are really good. You're going to see someone today who's been exposed to multiple adverse childhood experiences. And so a couple of things. Nearly 75% of high school kids have been exposed to at least one adverse childhood experience, and 20%, so 1 in 5, have been exposed to 4 or more adverse childhood experiences before the age of 18. So we see these kids every day, and it's not always obvious that they've been exposed to this toxic stress, and it's also not always obvious of what's going to happen because of that toxic stress. So today I'm going to go over some critical statistics, evidence-based screening tools, practical strategies that'll help you implement trauma-informed care in your clinical setting, and potentially together we'll be able to prevent many cases of future mental illness in these kids. So first of all, what is the long-term mental health impact of childhood trauma? Turns out when you ask U.S. adults, about 64% of them report at least one adverse childhood experience, and 17.3% report 4 or more. The most common adverse childhood experiences include emotional abuse, parental separation, so a divorce or loss of a parent, and household substance abuse. And kids from marginalized communities tend to face disproportionate risk, especially American Indian, Alaska Native children, where almost a third of them have been exposed to 4 or more adverse childhood experiences. And this part of the country, including Montana, Wyoming, Alaska, Idaho, we need to be particularly sensitive to our Native American neighbors and also obviously in Alaska, the Alaska Native children. COVID-19 had a pretty significant impact that actually layered on additional adverse childhood experiences. More than 140,000 kids across the United States lost a primary caregiver during the pandemic. And in 2020, emergency department visits for mental health increased almost a third for adolescents. Teen girls had an increase of 51% in suspected suicide attempts in early 2021. So you can see that COVID-19 had a pretty significant impact. So childhood trauma affects brain development. I think many of us know that. It leads to neurobiological changes, actually affects brain volume. The hippocampus is actually one of the parts of the brain that's affected. You get reduced volume, and children with trauma show measurable decreases in the brain region that's critical for forming new memories, which is the hippocampus. There are other impacts on the brain. I won't go into the details. They affect the prefrontal cortex, which is this part of the brain that's executive functioning. The amygdala, which responds to trauma, it gets super sensitive. But I think what's critical to recognize is toxic stress in childhood consistently lights up the HPA axis. The HPA axis is in charge of setting off and triggering the fight or flight response. And when it's constantly on, that's something that has long-term impacts and ultimately contributes to the long-term impacts of adverse childhood experiences. The other thing is constant turning on of the HPA axis leads to long-term impacts actually on the genes. In 2024, there was research that showed that there was significant and demonstrable impact on the genes of someone who's been exposed to trauma for a significant period of time. So in terms of the impact on children, kids with ACEs have 2 times higher odds of depression and nearly 2 times higher odds of anxiety disorders. And for kids with 4 or more adverse childhood experiences, they have 25 times a higher rate of suicide attempts. And that's something that we found during the pandemic. So again, has a direct impact on mental health outcomes and in particularly serious is a huge spike in the risk for suicide attempts. Over the lifetime, there are long-term adult outcomes as well. There is a dose-response relationship, which means the more adverse childhood experiences someone has, the higher the risk for sort of bad physical and mental health outcomes. So somebody with no adverse childhood experiences, which again is only about a third of the population, that's the baseline. And so if you compare to the baseline, someone with one adverse childhood experience has 1.5 times increased risk of mental illness in adulthood. 2 to 3 ACEs, there's a 2 to 3 times increased risk. And with 4 or more ACEs, the odds are 3 times higher for mental illness and 12 times higher for suicide attempts in a lifetime. There's also an economic impact, which again, if you're doing advocacy and able to talk to policymakers and stakeholders, I think it's important to recognize the economic impact is about $750 billion annually in the United States. That's the cost and impact on the entire economy of adverse childhood experiences. And it turns out if we had early intervention, we could prevent 21 million cases of depression and almost 90% of suicide attempts among high schoolers. Almost 90% decrease in suicide attempts if we were able to magically get rid of ACEs. Obviously, we won't get rid of ACEs, but early prevention and intervention is critical if we're actually going to move the needle on any of this. So how do you implement trauma-informed care in pediatric settings? Well, SAMHSA is, which is the United States sort of national administrative body that takes a look at mental health and substance use disorders, studies, intervention, so forth. They publish what's called a 4R framework, and that's their foundation for all trauma-informed care. So number one, you realize the widespread impact, remembering that 2/3 of your pediatric patients have been exposed to trauma. The second R is recognize signs in patients and families, their behavioral problems, somatic complaints, or physical complaints, and developmental regression. The third R is respond by integrating knowledge into all interactions from check-in all the way to the examination. So being sensitive to the potential impact of trauma, and just assume that everyone you're meeting has a high likelihood of having been exposed to childhood stress. And then the fourth R is resist re-traumatization. Offer choices, allow the patients and families to feel empowered, explain procedures, over-explain them if you have to, and respect boundaries. The American Academy of Pediatrics published a 5-point strategy to implement trauma-informed care. Number one, be aware of the trauma prevalence. Again, 2/3 of the population. Number two, take a look at the readiness of your practice to address trauma. Number three, detect exposure to trauma by evidence-based screening. Number four, manage as best you can with evidence-based approaches. And then number five, integrate being trauma-informed across all practice workflows. Again, it's really not rocket science. It's being very aware that almost anything can potentially trigger folks who have been exposed to chronic childhood stress. So what are some of the screening tools and implementation tools? Well, there's something called PEARLS, P-E-A-R-L-S. It's a pediatric ACEs and related life event screener. It's valid for ages 0 to 21, takes about 5 or 10 minutes to implement, has 17 items, and it covers ACEs plus additional stressors. It was actually successfully implemented in California, serving over 1 million children since 2020, and some payers will actually reimburse for this sort of screening. There's something called the CATS, C-A-T-S, which is a child and adolescent trauma screen. Based on the DSM-5 criteria, it's a 15-minute administration. It's available in 7 languages, including Spanish and Arabic, and it screens for trauma exposure, symptoms, functional impact, and suicidality. So again, another very useful tool to help us understand what our patients have been exposed to. So some recommendations, if you can implement this and then integrate into the electronic health record, that makes And that makes the workflows a lot easier. It streamlines how you deploy the strategy. Doing a brief training is important. I think, teaching your staff, telling them why this is important, and really, once you give people the why and you explain it, it's really hard to ignore because we've all been exposed to adverse childhood experiences of one form or another. Universal screening in behavioral health ends up really identifying trauma in over 50% of patients, so screening works. And if you can administer this during the waiting time in the waiting room, that can be pretty useful. After all, that's how a lot of the other screeners are presented to patients. So doing this sort of work has a positive impact. After trauma-informed training, there's evidence, and it makes sense, right? There's evidence that there's significant improvement in provider knowledge and comfort treating trauma-exposed patients. So doesn't become this sort of black box, this mystery of, oh my goodness, what I do with folks who've been exposed to trauma. Once you've been exposed to the training and understand really the simplicity, but also the power of this, providers, clinicians get a lot more comfortable with helping this patient population. Train-the-trainer models tend to be the most cost-effective, so that's definitely a way you can go, and they generate sustainable change. In terms of patient outcomes, you get reduced hospitalization length of stays, decreased emergency department utilization, improved family engagement and treatment adherence, and you get early identification, which lead to better long-term outcomes. And again, we sometimes have to talk about the economics of this, especially for advocacy purposes. The United States has the potential to save $1.4 billion over a decade when implemented in social services and schools. And the screening cost per child ends up yielding much, much more powerful returns on this investment when it comes to healthcare savings over the life of the child and ultimately the adult. So how do you support children who've been exposed to abuse, neglect, and violence? There are evidence-based therapeutic approaches. One of the most powerful, if not the most powerful, sort of gold standard approach is trauma-focused cognitive behavioral therapy, also known as TFCBT. They have really, really high effect sizes, which basically mean the impact and the benefits of TFCBT are demonstrable and powerful. The effect size is about 1 for PTSD, and it's about 1 for depression. And that, if you care about statistics, is very high. There are 12 to 16 weekly sessions. They're clearly superior to treatment as usual, and the benefits of this kind of intervention are sustained after a year. There are lower dropout rates with TFCBT than other trauma-related treatments, and these can be given via telehealth with similar outcomes to in-person care. You also have EMDR, and studies have shown that the effect size for EMDR is also pretty good, not quite as high as TFCBT, but it's around 0.6. That's for PTSD symptoms. The completion rate is pretty high at 96%, and it doesn't require detailed verbal recounting of the trauma, which again is ideal for younger children. And depending on the complexity of the presentation, there are 2 to 12 sessions that are made available for patients who go through EMDR. There's also something called parent-child interaction therapy. Huge effect size at 1.7 for behavioral problems. The live coaching model helps parents in real time, reduces the risk of re-abuse, and it's especially effective based on the research for kids who've been exposed to physical abuse. You got to involve the family. That's critical, and that's something a PCIT does. Other evidence-based approaches include child-parent psychotherapy, or CPP. It's the gold standard for ages 0 to 6, and addresses intergenerational trauma. If you can get a family member, a caregiver, to engage in TFCBT for the child, that improves outcomes. And really getting the support of the non-offending caregiver, the caregiver that is safe, is essential, because that caregiver often needs support as well. So in terms of some practical strategies for you, include caregivers in safety planning, provide psychoeducation about trauma's impact on behavior, connect families to parent support groups. Again, connection, connection, connection include the family system, get them plugged into the community system, address caregivers' own trauma history, and teach families and your staff about the long-term genetic impact of trauma, and why it's so important to really intervene as soon as possible. If you can, coordinate with the community. Like I was saying before, connecting people is critical in all of this. Engaging in multidisciplinary team approaches can be powerful. There are children's advocacy centers that can reduce re-traumatizations through coordinated responses. Integrate with schools. School systems are often and are becoming better at being trauma aware, if not trauma informed. Child Protective Services are getting better at that, and legal systems over time are getting more educated when it comes to the impact of adverse child experiences. There are school-based interventions, and again, not all schools have this, but it might not hurt to introduce your school district to some of these. There's something called CBITS, which stands for Cognitive Behavioral Intervention for Trauma in Schools. This is a group intervention that shows really significant symptom reduction in groups of kids who are given CBITS. Something called Bounce Back, which is for kids in elementary school, and it's integrated with a school day. And all of this includes training that teaches staff how to really provide a trauma-informed environment that reduces the triggers to children who've been exposed to trauma. In terms of technology, telehealth delivery of some of these interventions have been shown to be very effective and work very much equivalent to in-person delivery of some of these services. This is especially useful for rural populations, as you know, in our part of the country, and that's what Frontier Psychiatry does. You get higher caregiver satisfaction rates because they don't have to drive all over the place to get access to care. So in closing, what can be our role? Well, let's screen universally. You can use the PEARLS or the CATS at well child visits, and these take just 5 to 10 minutes and may be reimbursable. Use a framework that'll help everybody remember how to do this. So use the 4 R's, for example, where you realize, recognize, respond, and resist re-traumatization in every interaction with kids. Get to know your referral network. Try to find providers that have been trained in TFCBT or PCIT in the community. Brief training can make a difference, so training your staff, even just 6 hours of education, significantly improves outcomes for the children that you care for. And focus on relationships, connections, community, families, school systems. Safe, stable, nurturing relationships are the foundation of healing, and a caring, loving, and safe adult in any one of these settings can have a huge impact. Remember these numbers. 75% of your adolescent patients have experienced trauma. If a child has 4 or more ACEs, the suicide risk goes up by 25 times. And early intervention could prevent up to 90% of teen suicide attempts. If you come in with a trauma-informed approach today, you can actually break the intergenerational cycles of trauma. Together, we can definitely do that. We have a unique opportunity as clinicians who care for children and families. Every trauma-informed interaction might help rewire the brain just a little bit, teaching these children that there are safe places and safe adults and safe systems out there. Every screening can identify a child who needs support, and every referral can connect a family to life-changing treatment. The evidence is pretty clear. Trauma-informed care works, and the question isn't whether to implement it, but how quickly we can transform our practices to meet the needs of children exposed to trauma, which is an urgent need. Thank you for that, and we look forward to talking to you soon.